Good evening. Tonight's show is a very interesting and informative show. Please stay tuned. We're going to talk about infectious disease. Good evening. Tonight's guest is Dr. Mark Hofstetter. He's a board-certified internal medicine physician and also infectious disease specialist. Mark, welcome to the show.
Thanks, Gene. It's good to be here.
As you've read in the paper recently, the newest scare out there is MRSA. It seems as though we're being overrun by it. And give me a little bit of a hint what an MRSA is, and should we really be worried about it?
Sure. Well, MRSA is an acronym for methicillin-resistant Staph aureus. It's a type of bacteria. As you know, Staph aureus is a very common bacteria. We see it in a lot of patients. It's a more resistant bacteria than the usual Staph aureus. Methicillin was an antibiotic introduced in the late 50s and early 60s, and Staph aureus became resistant to it, and therefore we have developed MRSA. Now, there's two types of MRSA in general. There's a type that we've seen in the hospital for many years, but more recently, and this is what's probably caught the news, is the development of what we call community-acquired MRSA, which is a strain of MRSA that is somewhat less resistant than the hospital strain, but often causes more disease in terms of abscesses and serious disease. Okay.
When we hear or get MRSA, if you could describe some of the clinical things, in other words, if you, if you got a lesion, everyone out there, we don't want them to be afraid and run to the doctor and say, I got MRSA. What do we look for?
Well, community-acquired MRSA in general causes skin infections, skin and soft tissue infections. Other infections also can be caused by community MRSA, but in general, the population sees it on their skin.
Who's at higher risk to develop that?
Well,
community acquired.
Right. Almost anyone can develop it, but we usually see it in younger adults. You can be seen in children as well, but it can certainly be seen in active members of the community.
Okay. And I read recently where there were some athletic problems, issues, especially at neighboring high school that was tested. Give us a little update on that and what your thoughts are there.
Well, certainly community-acquired MRSA is easily transmitted back and forth between individuals. It seems to have a propensity for athletes, not only student athletes, but it's also seen in college, and there's been some publications of professional athletes as well having outbreaks of it. It probably in those situations has to do with hygiene in male locker rooms as opposed to anything else, but it's easily transmitted.
Are there any tips regarding cleansing, cleaning equipment for students, for student athletes, if if you're a parent out there and you have some children participating in sports? And what are the high-risk sports, by the way?
Well, contact sports are thought to be the highest risk sports. We've primarily seen it in football players, and that may have to do with the equipment that they use in addition to the sweaty conditions, but you can almost see it in any type of athlete. And the issue in terms of cleaning is good personal hygiene, so good washing with antibacterial soap, using your towel on your own and not sharing it with anyone else. And certainly, although we're not 100% certain, we think that cleaning equipment and cleaning the uniform in addition also helps.
Okay, I've read recently where a lot of athletic teams actually switch off and have two different practice uniforms and then they're laundered professionally. Is that becoming the standard for the most part?
Certainly in some of the suburbs that I've read about, that is becoming the standard. Unfortunately, there's a lot of information that's out there, but no great data as to whether that is or not, but it certainly seems prudent.
Okay. Are there any, so let's say your child gets this, or quote-unquote a member of an athletic team gets this particular disease? I mean, is this something that can spread rapidly and rampantly, or is it something that's usually isolated to somebody who's in contact with somebody else?
Well, it can spread fairly rapidly among individuals. It doesn't necessarily have to, but it certainly can. It's certainly eminently treatable. It's just a matter of recognizing it, making the diagnosis. Sometimes patients, in addition to antibiotics and local care, also need, surgical drainage.
Okay. What would be the best words of wisdom if you're concerned that you or your child has an MRSA type infection, or what should we look for, and then what should we do?
Well, often the MRSA is characterized by a skin lesion, which a lot of people call a spider bite. We in infectious disease think there's one bad spider out there that's biting everyone. But in general, it does look a lot like a spider bite. It's not really. It's the beginning of an abscess that's developing. And so if that happens, it's important to see your physician to get the area cultured, if at all, identify the MRSA, and then to begin on treatment.
Okay. Routinely, from the time that you get this first, is it seen more in the extremities, or can it be anywhere?
It can be anywhere.
Okay.
I mean, although more commonly in the in the arms and legs, it can be seen anywhere.
Okay. And so would you, how long from the time this little pimple, boil, or lesion occurs until it starts getting larger and more painful, for the most part?
Well, that can be actually very quickly. Some people are slow, but it can be just a matter of hours to days to get a fairly large lesion.
Okay. As far as contact from individual to individual, as long as your best advice then is cleanliness?
Yes, it's still,
okay.
That's always the best advice for infectious disease is hand hygiene.
Wash your hands. Are there any personalized, I see these tubes that these folks are running around with. Any better than anyone else, or are they all pretty good?
They're all very good. They're all alcohol-based. They have good ability to kill MRSA, so they are very good to use in absence of soap and water. Okay,
and Kim and Ryan are diligently running some references. If you scroll through this, you can look up more on the government sites. There's a CDC website. There's also American Journal of Medical Association website, NCAA, Mayo Clinic, and AHA, which are the hospital websites, which will be scrolling on the screen. Dr. Hofstetter, again, is a board-certified internal medicine specialist with a degree in infectious disease. Mark's been doing this for more than a few years now.
Yeah, as you can tell.
Me too. And we're talking tonight specifically about infectious diseases. However, we've started with the MRSA. As you said, there are a significant amount of antibiotics that can be used to treat this.
Yes, in the community-acquired MRSAs, there are a lot of antibiotics, even oral antibiotics that are available as opposed to intravenous antibiotics, things like sulfa antibiotics like Bactrim or Septra. Clindamycin is certainly available. Those are the two major oral antibiotics, but there's a lot of other oral antibiotics that can be used.
Okay. As far as cleaning things, is there any cleaning equipment or solutions that are better than the other ones that you're aware of? Or?
I'm not really aware of anything. I think most of them that do a pretty good job of cleaning should be able to kill the Staph aureus. I mean, certainly bleach compounds are notorious, but they may be tougher on the skin. But almost anything's good. And in terms of laundry, almost any commercial laundry soap is fine. Sure.
Okay. MRSA. Hospital acquired, it's kind of funny, I'm going to be doing a laparoscopic ventral hernia on one of my friends in January, and he said to me, and I've never had a patient ask me this, he said, well, I'm worried, I read in the paper about this MRSA that you get at the hospital.
Mm-hmm. Well, MRSA at the hospital is somewhat rare to acquire just coming in from the outside and to get it in a simple surgical procedure that you're going to perform on your friend. I mean, certainly we do see it in patients who have been in the hospital for a long time, have multiple medical problems, or people who have been in nursing homes and so on. That's more common to see MRSA in that setting.
I see. So then the general public out there that's watching, if you're going to go get your tubal ligation, your gallbladder removal, hernia repair, knee scope, knee surgery, for the most part, that's more of a rare occurrence than.
Right, that's more of a rare occurrence. Now, the other unfortunate problem is people coming in with community-acquired MRSA that's living on their skin and not recognizing it because it hasn't caused any disease, and then getting infections from that. But,
Okay.
But that's harder to sort out, to say the least.
Some of the articles that I reviewed for this at the kind request of our staff showed that there are some hospitals that are now culturing for MRSA. Could you explain the reasoning behind that, and if you think that's a good idea?
Well, there are a variety of initiatives of hospitals that's been purported or proponents of the CDC, as well as some of the insurance industry in Western Pennsylvania, especially Highmark has a big initiative, that we think that if we can identify patients with MRSA when they come into the hospital, that we can prevent the transmission of MRSA to other individuals. I think that in some cases the data is a little bit weak, but I think we'll have to see what happens. It's certainly not a bad initiative, but I'm just not sure there's a whole lot of data there yet to prove it.
Is the insurance company paying for these cultures if they're done at a hospital that you know of? Or does the hospital charge the patient and the patient charge?
Well, it's all actually being absorbed by the hospital, although there is some incentive under the Highmark plan for payments eventually if certain criteria and points are met.
Okay. If you pick up somebody that is screened and they're positive and completely asymptomatic, that's, I would assume, a tough question as far as what you do.
You're absolutely right. In fact, I was just talking to my partners today about that same issue, and it's a tough question. There's no data whatsoever, and we're not sure what to do with these patients or how to handle them or whether to do anything, because certainly giving them antibiotics to an asymptomatic patient can make them symptomatic with other diseases such as C. difficile.
And I promised you I'd throw you softballs tonight, so I apologize. I'll lean off of the hardball Chris Matthew questions tonight. Tonight we have Dr. Mark Hofstetter, who's a board-certified internal medicine physician. You may have seen rolling across the screen there is some websites for MRSA. We don't have the ability to phone in tonight. Okay, let's switch gears a little bit. MRSA is treatable. Mark's an expert in it. If you need to get a hold of Mark, your internal physician, medicine physician, family physician, which would be your first line of attack, the hospital number hopefully will scroll across there for you to get a hold of those physicians. Mark is really a super specialist and really called in when the chips are down for the most part. Let's talk a little bit about, I guess we're coming upon pneumonia these days, cold and flu season.
Right.
Tell us a little bit about, are there any preventative things we should do, or anything new on the cold front?
Okay. Well, unfortunately, in the cold front, there's not a whole lot new. As we know, colds are, typically we characterize them as upper respiratory illnesses, which are caused by viruses. There's not a whole lot of medications yet available to treat any of these, although some are currently in trials, but as you know, past trials of some of these have not been so rewarding. So it's primarily an issue of hygiene, again, hand washing, trying to stay away from people who are obviously infected, covering your nose and mouth when you sneeze, and hopefully other people will do it as well. There are some over-the-counter compounds out there that people have said are actually good at preventing colds, such as these zinc compounds, vitamin C, everything. There's not a whole lot of strong data on them. They probably don't hurt, but they may well help as well.
When I was in medical school, I had my roommate was always taking these vitamins, and absolutely convinced. What's the one you mentioned?
Vitamin C, usually.
Yeah, there was some trace element or something.
Oh, okay.
I don't know. I guess you'll find he went into ENT, so what does he know? I guess. Now my good friend Dr. Vanish will be mad at me.
Right.
Okay, so the doctors, it's a conspiracy, so you guys can keep people coming that you haven't found the cure for the common cold yet, I guess.
Well, there's certainly people have tried, and there's been a lot of money put into the cure for the common cold, and it hasn't been found. I tend to doubt it's a conspiracy.
Okay, that's good. That's good to know. Back to the softball questions. It's cough, cold, and flu season coming up. Tell us, a little bit about the flu, how to avoid it, and who should be vaccinated, and are the vaccines effective this year? What are we looking at this year?
Well, so far we haven't seen much of a flu outbreak in our part of the United States, and in fact the United States hasn't seen much yet, but it's certainly coming into flu season. And although some years are not as bad as others, every year there is influenza in the community, an outbreak. And associated with influenza is basically a higher illness rate and a higher death rate, especially in susceptible individuals. So it's a very serious viral infection that we can actually prevent and can treat. And so it is important to try to mobilize forces to get people to not get this disease, because it does definitely cause severe disease, especially in the elderly or in patients who have other medical problems as well.
What are some of the symptoms, some of the early symptoms, and how do you differentiate it from, just a cold? How does the person out there watching, I just got a cold, or, this is the flu, I got to do something more?
Right. Well, it's sometimes very hard to differentiate the two. I would say that you're absolutely right that even experts often have a difficult time telling colds and flu apart. But symptoms that are typical for flu are the development of headaches. Usually initially people have cough and a runny nose. That goes away fairly quickly. Sore throat, they get severe muscle aches, fever, and chills are very common, and they have lethargy. They just don't feel very well. GI symptoms in adults are very unusual, so if you have predominantly GI symptoms, it's unlikely to be influenza.
Okay.
So that's how you kind of tell, and certainly you don't feel well. You get worse with flu.
Will you have shortness of breath or coughing up any sputum? Is that associated with that, or is that more toward the pneumonia line?
That's usually more towards the pneumonia line. Usually they don't get short of breath or have cough, but there are some people who have two different problems with flu. One is the development of influenza pneumonia. That's very rare, but that's a serious disease where the flu actually causes pneumonia. Okay. And there are people who develop secondary bacterial pneumonias after influenza as well. And
what are some of the tests that you would run? Somebody comes to your office, and you're trying to differentiate them.
Well, nowadays, we're very fortunate in the last few years that we have rapid screens for influenza.
Okay.
And that actually can be done in the office or in the lab or in the emergency room of the hospital.
Okay.
And they get results back very quickly. They're not 100%, but their sensitivity and specificity are very high to be able to exclude whether a person has flu or not.
Okay, and exactly what is that test? Because this is again new to me, hiding in my OR all the time.
It's just actually a swab test where they swab either the nose or the back of the nose or the throat, and then just send it to the lab and look to see if it's an antigen. That means that the protein product that the flu is producing is identified.
Wow, that's pretty interesting. Now, is that available in physicians' offices or just like the emergency room?
It can be available in physicians' offices if they have and many physicians do have the appropriate material. They usually have to send it to the lab to be done.
Okay.
But still the turnaround's fairly quickly.
Okay. Again, if you're just tuning in, Dr. Mark Hofstetter's infectious disease specialist at Canonsburg Hospital, an expert in infectious disease. I've known Mark for a number of years and truly is an expert. In regards to tonight's discussion, which we've talked about MRSA, the flu. Who normally gets the flu, Mark? Who out there is more at risk than not?
Well, a lot of people are at risk. Yeah, it can be seen in almost any age group. Certainly young children are at risk. Actually, children in school are at risk because of the fact that they're in school and it's often transmitted back and forth. And then adults are at risk as well. And nursing home patients as well. It's at risk in almost everybody. The people who get the most seriously ill are usually the elderly or the very young.
Okay. Have we seen that at the grade school or high school level where you can get the flu?
Yes, definitely.
Since we popped into that subject, meningitis, pretty serious problem.
Right.
Do we see that a lot? Is that something that's of a concern to the high school population, grade school population, college population?
Well, it's not as big a concern. We don't see that many cases, very fortunately. It's certainly a devastating disease. It's probably the most commonly seen is when individuals are cohorted or living together. So that's often when students go off to college or military recruits. And that's the time when we usually do suggest that they get meningitis vaccination.
Okay. And how long is that vaccination good for? I have a daughter going off to college next year. When should she get it, and how long would that last?
Well, the vaccination is good for 5 years, and they should get it before they go to college. Many colleges are requiring it nowadays.
Okay.
It protects against meningococcal meningitis, which is a certain bacteria, and that's the most devastating type. Usually, though, after 5 years, you don't usually need it because your living situation changes. You're no longer in those dormitories.
I got you. Unless you're on the 5 or 6 year plan, depending
Right.
on what college you go to, or
Right, exactly.
I understand. As far with the athletic team you play for,
Right.
we'll leave the ones out in the middle of the state. There's no reason to throw stones out toward the middle of the state there. Somehow sports always seems to come up on this show somehow. Besides meningococcus vaccine, do you get I know you have pneumococcus. Do you get is there a series, or is it just the one you get?
For students going off to college, it's just meningococcus. Okay.
Is that pretty much the one that they would get if they were
Right, that's the age group and the most serious one.
Okay.
Pneumococcal vaccinations we don't usually give to college students. That's typically a vaccine we give to older individuals or people with underlying disease. And that's primarily to stop pneumonia as opposed to meningitis.
Okay, so then that's a great segue. That's why I've done this show for a number of years.
I can
into
tell.
Pneumonia, as I stumble into yet another category, fortunately. So let's talk a little bit about pneumonia. Who gets pneumonia? I love beating up people that smoke because they got to really try to stop.
Right. Well, people who smoke certainly are at risk for pneumonia. Just elderly people alone are at risk for pneumonia. People who have smoked and have lung disease are at risk for pneumonia. And patients who also are, immunocompromised or have other serious medical problems like diabetes, heart disease, even asthma to some extent are at risk for pneumonia. So the current recommendations are for pneumonia vaccine, which is a vaccination against pneumococcus, which is the most common bacteria to cause pneumonia. And we usually give those in patients who are greater than 65 years of age or in younger patients who have had other medical problems like we talked about.
Okay. How about I have a couple of friends that actually have had kids that have had transplants, kidney, heart, lungs, and are they at high risk also for these things?
Yeah, they're at high risk, and they're usually immunized after transplants.
Okay,
and
so
often
somebody
usually
takes care of that, obviously.
Right.
Okay.
Right.
If some of the symptoms of pneumonia, if somebody were going to get pneumonia, again, these things kind of blend together, at least to me, the flu, the cough, the cold. Tell us, when should you seek out medical attention, if you think you have pneumonia, and what should we look for?
Well, pneumonia caused by bacteria are some of the symptoms that we talked about before, but it's more prominent than with flu. People typically have fevers, chills. They have a fairly severe cough. It's often productive of sputum. They may get chest pain. They may get shortness of breath. So if you have any of these symptoms that are especially persistent, you certainly should seek medical attention because most pneumonias are eminently treatable, but still if you come late, it's very difficult.
I saw that you can get an MRSA pneumonia. Is that more in the hospital variety as opposed to a community-acquired pneumonia?
Well, it's more hospital-acquired, and typically, and usually patients coming in from the nursing home, seriously ill patients, people who have been on the ventilators, the artificial breathing machines for a long time. There are some cases of community-acquired MRSA pneumonias. They're very, very rare, but very serious cases.
Okay. If you have a loved one that's in a personal care facility, nursing home, is there any advice that you'd have, to give to those people that, visit frequent, their parents, grandparents, or loved ones?
I think it's the important things that we talk about is hand hygiene for themselves. Try to stress hand hygiene with the staff. Usually, hopefully, the staff does good hand hygiene in terms of washing, but that's very important. And try to keep them up to date on their immunizations for pneumococcus, for influenza. Those are kind of the major issues. It's a difficult situation to say the least.
I saw that there's two types of, is it influenza vaccine? You can either get the nasal or the shot.
Right.
Is one better than another? Should you go to your doctor and say, better give me the nasal, or I want the shot, or vice versa?
They're both quite effective. There's one that's inactivated, that means a dead vaccine, and that can be given to everyone. That's the shot. The live vaccination is the nasal one that they spray into your nose. It only currently is approved for individuals up to 49 years of age, so it's not approved currently for the elderly, but it does seem to work. And as far as we can tell, they're fairly equivalent.
You set up to 49, and you mentioned elderly there.
Right.
I'm kind of feeling.
I'm sorry.
I'm feeling the heat here this evening.
Don't feel bad.
Okay. I keep getting these AARP cards. I keep throwing them away. If somebody out there can tell me how to stop those bombardment from the...
Eventually, you'll just accept it and take the discount,
Not me. No, I'm gonna fight this for quite a long time. We've had Dr. Mark Hofstetter tonight talking specifically about various infectious diseases. One that one of the athletic directors brought up to me was some of the wrestlers were getting these herpes-type lesions.
Right. There's an entity which has a great name called herpes gladiatorium. It's a herpes simplex virus that usually is spread from wrestler to wrestler because of the way that that sport involves, in which they're contact with each other and all over each other. And they get these outbreaks of herpes lesions. Can be almost anywhere on their face, on their body, from unfortunately rubbing up against another wrestler. It's pretty highly contagious and is spread pretty easily. So usually if there is an outbreak in addition to treatment, usually the wrestling season or the wrestling matches have to end for a while until all the lesions go away from everyone.
Okay, and you mean like the whole team?
Yeah,
wow. Usually
the whole team. I mean, if it's clear if somebody doesn't have it, but it's several wrestlers in a team that end up having it.
I got you. Is that treatable?
Yes,
okay.
It's treatable with antivirals, but usually they'll go away on their own as well.
Okay. Anything? We're moving quickly toward the end of the show. Is there any words of wisdom you'd have with our cough, cold, flu season, MRSA season quickly upon us?
Sure. I mean, I think the issues are always what your mother and grandmother told you, which is to wash your hands and keep clean, certainly using Kleenex. But in individuals, if you're out there and you really should have influenza vaccination, you should get it. You need to get it every year because the virus changes every year. And also if you're susceptible or you need pneumococcal vaccination, you should get that. That's not yearly, but we should certainly think about doing that. Try to protect yourself by vaccination and all these other measures.
Okay. And if you have children, young adults going off to college?
Right. We'd want to talk about pneumococcal vaccination. There's some other vaccines that are also required by college. Each college is different. Okay. Many of these kids are already having, as they're getting older, that they didn't have 10 years ago, like hepatitis B and A and so on.
I was just thinking about that. So also, it's not a bad idea to get a hepatitis vaccine?
No, it's not a bad idea to get hepatitis vaccines at all.
Okay. When I was growing up in medicine, there used to be a series of 2 or 3. Are they still that series?
Hepatitis B is a series of 3, but nowadays it's actually most children have already gotten them from their pediatricians.
Okay. If there are any questions, if you have any questions out there, I'd like to get a hold of Dr. Mark. You can give a jingle to the hospital. Your first point of entry should be your primary care physician, an internal medicine physician. We're fortunate to have a plethora of very, very well-educated docs around in the area. But any specific question, if you'd like to give a jingle to that number there, have a loved one, have a specific question that Dr. Mark could answer, I'm certain he'd be happy to do so by getting a hold of that number. Again, we'd like to thank Dr. Mark Hofstetter tonight, board-certified internal medicine, infectious disease specialist, for an excellent discussion and dissertation on our infectious diseases.
Thank you, Gene.
Mark, thanks for coming.
Thank you.
You're welcome. I'm not quite sure who our next guest is. I'm sure we'll have a few in January that will be quite exciting and interesting. I'd like to wish everybody a healthy, safe holiday driving season. Just be really careful out there. Keep the rubber on the downside. Just be careful and slow down, because we just had a very unfortunate accident when we had the first snowfall. About a week ago, we had a 24-year-old that was killed right on Route 19.
That's terrible.
So, it's quite tragic, and it's something. There's no reason to be in a hurry. Slow down. As always, have a healthy, safe, friendly New Year. We'll see you next year. peptic ulcer disease earlier. When we talk about Crohn's disease, it's not that common, is it?
Compared to gallbladder disease, compared to heart disease, compared to asthma, no.
Okay.
But it tends to strike the people who are sort of in the prime of their life. They're the younger people, the people who are going to school, getting their first job, things like that.
Right.
So it can be devastating on your life in general. It's not like a disease like hypertension or diabetes, which kind of hits you later in life.
So, but it's treatable for the most part?
I would say that most people can be treated. Probably less than 5% need emergent surgery, do poorly, and there are some people who die, but it would be unusual to die acutely, basically to be diagnosed today and be dead next week.
I'm with you 100%. Can Crohn's disease turn into cancer?
It's a yes and a no. How about that for a hedge?
A lot of yes and no questions.
We think that chronic inflammation of the intestine, especially the colon, large intestine, can lead to precancerous lesions or sometimes polyps. But I would say that if someone who's had Crohn's disease for more than 12 years, they increase their risk of having a colon cancer about 1% a year. Okay, so if you're 20 years old and get Crohn's, and then you're 32, you should probably start to get screened, start to be evaluated regularly for colon cancer, because indeed, 30 years later, you have a 1/3 chance of getting colon cancer.
I'm with you. Besides, there's this new thing I've heard about capsule endoscopy. Does that help at all? Not help? Have you find that
capsule endoscopy is an emerging technology. It's
tell us what it is.
Basically, what it is, it is a capsule, pretty large capsule actually, like a big vitamin. Has a TV camera on it, and has a little transmitter. And you swallow it, and it sort of tumbles through your GI tract. And you actually wear, just like any wireless device, you wear a little tape recorder or a little device that actually records the video.
I got a question.
Uh-huh.
Did you grow up with the Jetsons? Because, I mean, that's just tunes playing in my head right now. Is that bad? Remember that Astro guy?
Well, it's only bad because I'm thinking about that too.
He swallowed his television camera.
That's it.
That beams out. That's beautiful.
That's it. You could, I guess, get your own webcam and do that. I guess you could do that. So, but it's useful in bleeding that we can't figure out where.
Can you pick up any other TV? Could you watch the Penguins if you didn't like it?
Maybe if you had interference, I guess you get a little bit of small
I'm
bowel.
I'm messing with you now, man. I'm sorry. Go
That's
ahead.
all right.
Meet George Jetson is just going through it. I got a lot of problems. I got a lot of issues.
But I know that. So
okay.
I'm here despite that.
Okay,
anyway.
So we're back to capsule endoscopy, swallowing television stations.
The camera basically tumbles through your small intestine, and it takes pictures and it records them on a recorder.
It's like Alfred Hitchcock's Vertigo. I mean, this thing's spinning around.
That's it. And that is the problem because
I was thinking. Can I adjust this TV set? This thing is,
the technical problem with it is, when we do endoscopy, we actually have a fixed camera, and we look there. The capsule actually can tumble. It can travel like a snake, but that's unusual kind of tumble. So the picture's not really great. It needs to get the vertical hold
I bet you do.
So, but anyway, that would be...
Don't eat before you watch this movie. Go ahead. I'm sorry. Fantastic voyage through the
colon.
Now that was a good one.
There you go.
Okay.
So after we get the
every
the
once
pictures,
in a while, I just shouldn't ask it. Go ahead. You talk now for a while.
After we get
go ahead.
After we get the
is it helpful? Yes or no? Let's just go. Let's get to the end of the story.
The answer is if you got Crohn's.
Don't say yes or no one more time. That's all I can say.
The answer is it can be helpful.
Okay.
But there are some relative contraindications, which means there's sometimes you shouldn't do it. If you got if you have Crohn's that you could see on an X-ray, there's a big chance, a good chance that pill can get stuck.
Right.
And I know
then you'll need me.
And you don't mind that because you have to go in and take it out. But a lot of people don't like their intestines corked.
I understand.
Okay.
I'm with you 100%. Use this judiciously. You want to check with a gastroenterologist before somebody says, "Hey, let's go out and get a capsule endoscopy."
All right.
Perfect. You want to talk about irritable bowel?
Sure.
Okay. You're an expert in gastroenterology. What percentage of your practice would you say is irritable bowel related?
Well, probably 100%.
It can't be 100%.
But
You do other things.
No. What I'm saying is, I think it's very common. If you took 100 people off the street and you asked them questions that would suggest irritable bowel, probably half of them would have some form of irritable bowel. Now, what is that? Is that, it could be bloating, a little nausea, a little queasiness, a little too much constipation, a little loose stools. So it's a very common disease. Now, when it's debilitating or if it's really interfering with their life, that's when they're seeing me. The primary care docs that we deal with know how to treat average, routine, run-of-the-mill irritable bowel. But I'm going to see people who really are on that fringe, and that answer is about 20%.
Got it.
Get back to the first answer.
So, all right, well, let's get back to some of the more common things that we see, that you see, that I see. How about gallbladder disease? I'm certain you see a lot of that.
Right.
Talk a little bit about biliary dyskinesia. That seems to be a topic of the day, chronic cholecystitis.
Okay. Biliary dyskinesia, biliary simply means bile ducts and gallbladder. Dyskinesia, what's an easy term? Doesn't work right.
Right.
Would be an, okay, so.
Correct.
It doesn't feel good, it doesn't work right.
Correct.
Well,
kinesia is the study of motion. So
right.
There you go.
Yeah. So biliary dyskinesia, usually in younger women, usually with a family history of similar disorders. Mom has her gallbladder out, even dad may have his gallbladder out. We do an ultrasound, which is a sonogram test that sort of the simple, like the test
just
that
like we're
pregnant
checking
women
for
get.
babies,
Exactly.
right?
Okay. And we'll look at the gallbladder, and it'll look fine. There won't be a stone in there. It won't be thick. It won't be thin. It'll
So
look
you're
just
done. You're out of the
perfect.
woods.
Well,
Not quite.
no, I'm not out of the woods. That's where sort of I come in, and then we have to figure out what this pain's from.
Okay.
There's a test called a CCK HIDA. Basically, it's a stress test for the gallbladder. We inject the patient with a little tiny bit of radioactivity. It circulates in the blood, goes to the liver, goes to the gallbladder. And actually on the x-ray, or a special x-ray, we can actually see the gallbladder. And then we give them a medicine called CCK or cholecystokinin. We used to give them chocolate chip cookies with extra chocolate chips because all the fat in there. When you eat fat, your body releases CCK or cholecystokinin, basically making your gallbladder contract. All the techs were eating the cookies, so we had to use the medicine. Oh, we inject it with the medicine, and you would expect a response. The gallbladder, the job of the gallbladder is simply to store bile, store this detergent that the liver makes. And when you eat, to basically squeeze, release the detergent into the intestine, let everything mix up, like Dawn dishwashing liquid with fat. All the fat goes from big globules to little tiny globules, and you can absorb your fat. So we check, we want to see how well that gallbladder squeezes.
Got it.
We inject the medicine, and there's a certain parameter, certain percentage. We usually more than 35 and up to 100% really. If, say, we have a person who really looks like a bad gallbladder, talks like a bad gallbladder, but we can't prove it's a gallbladder, this is the test that's going to show if it really is a bad gallbladder. We do that, and if that number's lower, that's when you see that patient.
Well, we appreciate that very, very concise biliary tract discussion. There is certainly what we've spoken about. Clearly, there's an overlap between biliary dyskinesia, between ulcers, sometimes Crohn's, but much more likely biliary dyskinesia with a bad gallbladder, an ulcer. And that's where you come in.
Right.
So you're able to differentiate that for the viewing public.
We try.
Okay. It's Dr. Greg Machiko. You can get a hold of him at the number that should flash across the bottom of the screen. As always, if you have any questions, Greg would be more than happy to answer them by phone, telegram, telegraph, email.
Smoke signals.
Smoke signals. He's located at the hospital. Those tests that he spoke of, HIDA scan, CCK, endoscopy, can all be done at Canonsburg Hospital with state-of-the-art equipment, including the capsule endoscopy if you want to have that television camera flipping back and forth through there.
There you go.
Greg, thanks for coming. If there's any questions the folks at home would like to give Greg a call, we certainly appreciate it. As always, get a hold of docs at Canonsburg Hospital via the same number. Again, I'd like to congratulate Dr. Machiko for an excellent job this evening. I'd like to thank you for coming. I'd also like to congratulate all the high school sports teams who have done a phenomenal job this fall. Good luck to the winter sports, which are coming up shortly. And again, thanks to all the high school volunteers, adult volunteers at the cable network here to keep us on and keep us running. We certainly appreciate it. Now go out there, drive carefully, be safe, try to cut back on the cigarettes and fats so you don't see this guy, especially the fats. Have a good one.